Hi, welcome to the NEET PG Core Revision series in Pharmacology, where I will be taking up the important topics for the upcoming NEET PG examination. And today I'm going to discuss in pharmacology about the antimicrobial drugs, the drugs which are going to inhibit the protein synthesis and the ones which act at the level of the DNA gyrase. So let's get started. So first we are going to do drugs which are acting on the protein synthesis. So this is how the protein synthesis actually works or functions. So we have this mRNA and we have the 50S here and the 30S ribosomes of the bacteria. And the tRNA, it brings in the new amino acids for the proteins to be formed. So we have this two acceptor and the peptide side where the protein is being synthesized. Now, the various targets that we have via antibacterial drugs are going to act on the different levels here, right? So this is the first step where the new amino acid, it will bind to the acceptor site. Then after it binds here to the acceptor site, there is movement of the amino acid chain from the P site to the A site, and this we call as transpeptidation. Transpeptidation. Then after this, there is when the mRNA moves and these ribosomes, they glide over the mRNA. So there is shifting of this A and the P site, and a new A site here is revealed, while the older chain, it becomes now the oldest A site now becomes the P site. So this is called as translocation, right? So we are going to do the various mechanisms by which the antimicrobial drugs are going to target different steps here. Before that, see, I told you there are two subunits, 50 and 30S. Now, we sometimes are asked which are the antimicrobials which are targeting the 30S and which antimicrobials are targeting the 50S. So, let's see and remember an easy mnemonic for this. So, mnemonic to remember for this is buy at 30 and sells at 50. So, here you just remember the uppercase alphabets, right? Uppercase alphabets, and we are going to then remember the drugs from here. So for the first AT, A stands for aminoglycosides, T stands for tetracycline, and tigecycline. From the cells here, C stands for chloramphenicol and even clindamycin. Then E stands for erythromycin and the other macrolides. L stands for Linezolid, and S stands for streptogrammates. Then, so here we have the target site, whether it is 30S or the 50S ribosomes. Now we are going to actually discuss the actual mechanism of actions of these. So the first drug we have aminoglycosides. Now these are cidal drugs, bactericidal drugs. So what they do, they block the initiation, then they prevent the polysome formation, and they cause misreading of the amino acid. So when the wrong amino acid is incorporated, so the proteins which are going to be formed are going to be defective. So they are therefore cidal drugs. Tetracyclines, tigecycline, rest all of these drugs, they are static drugs except for aminoglycosides and streptogrammates. Normally, all the drugs which inhibit the protein synthesis are static drugs. Exceptions are aminoglycosides and streptogrammates. Then we have tetracyclines and tigecycline. So what they do, they are going to inhibit the attachment of tRNA. The first step here, when this tRNA brings in the new amino acid, so T for tRNA, T for tigecycline and tetracyclines, they inhibit this first step, okay? Alright, then moving on to the third group of drugs that we have is chloramphenicol. So chloramphenicol, it prevents the transpeptidation, right? The process where there is shifting of the whole peptide chain onto the A side. Then macrolides and clindamycin, they prevent translocation. So they prevent translocation. Linezolid. Linezolid, remember, it has a very particular binding, very peculiar binding site as compared to the others. It binds to the 23S fraction of the 50S ribosome, right? So it does not allow, so there is no formation of the initiation complex. The initiation complex is only not formed. No formation of initiation complex. Then we have streptogramins. So they are made up of two drugs. So one is quinopristine and we have dalfopristine. This is present in 30:70 ratio. So what the first drug is, it will inhibit the early phase. They inhibit the early phase of protein synthesis, and it also inhibits the second drug. It inhibits the translocation. So individually these drugs might be static, but because they are combined together they become cidal drugs. So these are the various mechanisms of the drug which act on the protein synthesis. So moving on to the important aspects of each one of these drug groups. So first, very important, is aminoglycosides. The aminoglycosides, these are, as I told you, bactericidal in nature, and they are specifically active against the gram-negative bacteria, even against the pseudomonas. But what are they not active against? So they are not active against anaerobic organisms, anaerobes, and gram-positive organisms, because they require oxygen for entry into the organism. So if there is no oxygen, like in anaerobes or in anaerobic conditions like in this pus and all, so they're not going to be very, very effective. Now, which is the most common resistant mechanism? Resistance is acquired by the organisms by which mechanism? Which is the most important is enzyme or enzymatic inactivation, right? So this is the most common resistance mechanism, but it is not seen with the drug amikacin. Therefore, it's a broad spectrum and there is less resistance, yes, to this particular drug. Now, aminoglycosides have important toxicities. So, three important toxicities which are seen with aminoglycosides. It is ototoxic, it is nephrotoxic, and it is neurotoxic, right? Remember, ototoxicity is dependent upon the concentration. Nephrotoxicity is usually dependent, it shows the time. So it is, ototoxicity means higher the concentration, more will be the concentration of the drug in the ear and ototoxicity occurs. And nephrotoxicity is usually time dependent, right? Neurotoxicity is because it will inhibit the calcium entry and therefore decrease the acetylcholine release. That's the logic of it being neurotoxic. Therefore, it is not given along with neuromuscular blockers as such. So which is the most nephrotoxic drug? Out of these drugs, we have neomycin and gentamicin. Remember, these drugs are nephrotoxic. So whenever there is, you always have to check for the creatinine clearance. And if it is less, you will have to decrease the dose of the drug if it is absolutely required, this particular drug. So in elderly patients where already there's a decrease in creatinine clearance, we prefer not to give this as a first line drug, but in case it is important, you have to comply with the creatinine clearance and then calculate the dose. It has to be decreased and never combine it with another nephrotoxic drug. For example, we have vancomycin, right? Amphotericin B. We should not be combining these two. Then most ototoxic. Now, ototoxicity again, it is of two types. One is auditory, other is vestibular. Remember, it can cause deafness and which is irreversible. Nephrotoxicity is reversible once you stop the drug, but ototoxicity, if the hearing deafness occurs, hearing loss occurs, that is irreversible. So auditory, which is the most ototoxic, A for auditory, A for amikacin. And vestibular, we have streptomycin. Okay. So avoid giving this drug in patients who have myasthenia gravis because they already have weakness of the muscle. So if you give this drug because they're going to decrease the acetylcholine release, they're going to aggravate myasthenia gravis. So avoid giving in myasthenia gravis patients and with neuromuscular blocking agents because that will also aggravate the condition. Now, absolute contraindication also exists for pregnancy. So we do not give this in pregnancy. It's a teratogenic drug. What are the uses? Let's do the uses now. So in case of plague, tularemia, tuberculosis. So here we are using streptomycin. Then in tuberculosis, right, second line drug, we can use streptomycin, reserve first line actually. Then we have capreomycin, kanamycin, etc. These drugs are there. Then endocarditis. Endocarditis. This is used along with penicillin. Remember, penicillin breaks the wall, cell wall, and allows aminoglycoside to enter. Mixed infections also it is very important because penicillin takes care of the gram positive and this will take care of the gram negative. Then for pseudomonas infections, pseudomonas infections, you give aminoglycosides along with ceftazidime plus aminoglycosides, right? Gentamicin, tobramycin works. Gentamicin and tobramycin. Now, remember another important thing about this drug is that these, if you give it orally aminoglycosides, they tend to get ionized. So because of this, they tend to get ionized. So they are not absorbed. They are not absorbed orally because it gets ionized, and you know that ionized fractions do not get absorbed. So they have to be given by a parenteral route like intermuscular, right? So can we still use them by oral route? Yes. If you only want the local action, you can still use them by the oral route or through the oral route. Where is it used? So we have a drug called as neomycin. Neomycin. It is used orally for gut sterilization. So you read the action in the GIT, in the gut only. So gut sterilization. Then oral paromomycin. We can use this in case of intestinal amoebiasis. Again, the target is in the intestine itself. All right, moving on to the next group of drugs we have is tetracyclines. Now, tetracyclines, now these drugs, the most common resistance mechanism here as compared to aminoglycosides, here we have the efflux mechanism. Efflux mechanism. Okay. Now, the important uses, how you can remember, we can remember a mnemonic, lymph scar. Remember, lymph scar. So, it can be used in lymphogranuloma venereum. Then it can be used in SIADH. We use the macrolide. C stands for chlamydia, cholera, and we can use doxycycline. A stands for atypical pneumonia. Though drug of choice is macrolides, but you can use them, atypical pneumonia. And R stands for rickettsia. Again, we can use doxycyclines. Even we use it in scrub typhus fever. Okay. So S can also stand for scrub typhus fever. Now, very, very important are the adverse effects. So they have a lot of adverse effects also. So all the tetracyclines, they are contraindicated in case of kidney disease, except for doxycycline. So this is the only tetracycline which can be given safely in renal diseases. Now we have another mnemonic to remember the ADRs of tetracycline, and we can remember easily by tetracles. Easy? Tetracles, tetracycline, tetracles. Okay. Now, T stands for teeth turn yellow. So you see here, there is discoloration of the teeth, yellowish discoloration of the teeth, ill-formed and they are discolored. E stands for, can cause epigastric distress. Another T stands for, it is teratogenic, because it can cause bone and teeth defects in the fetus. R stands for, it can cause renal toxicity. There is a condition called as Fanconi syndrome with seen with expired tetracyclines. Also, there can be rash. Then A stands for, so A stands for ADH release is inhibited. C stands for chelation is seen with iron and calcium. So they should not be given immediately together, right? We need to keep a gap of at least 2 to 4 hours. Then L stands for liver toxicity. So L stands for, it is hepatotoxic potential, there is liver toxicity. Another E stands for ear toxicity. So it has a feature of oral toxicity as well, and the drug is minocycline. And S stands for superinfection. So all the broad spectrum, tetracycline is a broad spectrum antimicrobial. So usually all the broad spectrum antimicrobials, they have this problem of causing a super infection. So they are used for one type of infection, and because they are going to suppress the intestinal flora, the good bacteria, so they lead to super infections in the patients. So tetracyclines as well as the chloramphenicol, they have this issue. Now, coming to tigecycline. Now, tigecycline is given only IV, and again, it's a broad spectrum drug. Just like tetracycline, it's a broad spectrum drug and it is safe in kidney disease. Unlike them, it is safe in kidney disease. So, it can take care of MRSA also, tigecycline and VRSA. Then we have some newer tetracyclines like iravacycline, which can be given IV for intra-abdominal infections. Intra-abdominal infection. Omadacycline can be given IV, can be given oral for community acquired pneumonia. Then we have sarecycline, can be given orally for acne vulgaris. So these are some of the newer tetracyclines. The next we have is chloramphenicol. Now this is one drug we don't use as such, and its adverse effects are more important as compared to those uses. So the question is usually asked on its adverse effect mostly. So what is the major or important area associated with it? It's called as the gray baby syndrome. See the baby here, the baby turns gray in color. It is called as the ashen gray color cyanosis. That's why we call it as a gray baby syndrome. So why is this gray baby syndrome occurring? Because in neonates, especially in the premature neonate, if you give chloramphenicol, their enzymes, the liver, they're not very well developed to metabolize chloramphenicol. Even their kidneys are not very well developed so that the drug can be excreted. So there is increase in the levels of chloramphenicol in the blood, and that leads to this toxicity. So this is because of the immature liver enzymes, number one, and number two, there is due to the immature excretion pathway. The kidneys are still developing in that child. That leads to gray baby syndrome. Then chloramphenicol also causes bone marrow suppression. Now there are two types of bone marrow suppression. One is type A, one is type B. In type A, it is dose dependent. We know that this is occurring in this patient. It is reversible as such. But type B, we are more worried about because this is idiosyncratic. Right? Type B means idiosyncratic. Any kind of dose can trigger this, leads to aplastic anemia, and therefore this is very, very dangerous. Because of these side effects, we do not prefer to give it to the general population. So we have better drugs available, safer drugs available, so we don't use them anymore. All right. Then we have macrolides. The third group here we have today is macrolides. So macrolides we have azithromycin, roxithromycin, and erythromycin. So the uses of these macrolides in pertussis and in diphtheria, we use erythromycin. Erythromycin. For atypical pneumonia, the drug of choice is macrolides, especially we use azithromycin. Gonorrhea, drug of choice is ceftriaxone. But we can add azithromycin. Toxoplasmosis in case of pregnancy, we use spiramycin. H. pylori, we use clarithromycin. Okay. Now, ADR is important. Again, we have a mnemonic called as macro. M-E-C-R and O. So, macro stands for motilin receptor stimulation, which can lead to increase in the motility of the intestines, and it can trigger loose stools. Then A stands for allergic reactions. Allergic reactions. C stands for cholestatic jaundice. It is mostly seen in case with erythromycin, right? And RO stands for reversible ototoxicity. Again, mostly seen with erythromycin group. Now, nifetromycin actually, it is made in India. Made in India. That is important. It binds to 50S ribosome, binds to 50S ribosome, and what is the use? In case of drug resistant pneumonia. Use is in drug resistant pneumonia. Then clindamycin, important things to know about clindamycin. It can cause, that means you're using clindamycin, but what it can cause, it is one of the drugs which is known or implicated in the causation of pseudomembranous enterocolitis. Remember, clindamycin can cause, third generation cephalosporin can cause, then aminopenicillins can also cause. And what is the treatment of pseudomembranous enterocolitis? The drug of choice we have fidaxomicin. We can also give vancomycin, right? It is hepatotoxic, yes. And what are the uses of clindamycin? Number one, it is used for anaerobic infections, but where? Above the diaphragm. That is supradiaphragmatic, like in the lungs and the brain. So we use it here. And number two, it is used for toxic shock syndrome. Coming to the next drug, we have linezolid, torozolid, and radasolid. Now this is important. It binds to 23S fraction of the 50S ribosome. We've already done that. So where it is used, it is a drug of choice for VRSA pneumonia, because otherwise we can use daptomycin, but daptomycin, it cannot be used in VRSA associated with pneumonia because that gets inactivated by the surfactant in the lung. So there we use VRSA, we can use it in VRE as well. ADRs of linezolid, that it is a MAO inhibitor, therefore it can lead to serotonin syndrome. Serotonin syndrome, especially with drugs which increase the level of serotonin, right? With the drugs increasing the serotonin levels. Then it can also therefore trigger cheese reactions, and it can cause bone marrow depression. Streptogramins, quinopristine, dalfapristine, 30:70 ratio. So it is also used for MRSA, VRSA, and VRE. Then we have tacrolimus. Now, tacrolimus is not used in an antimicrobial. It is a macrolide, but it has a very good immunosuppressant action. So, it is used in cases of organ transplant. So, we are going to do them when we do the immunosuppressant drugs. So, fidaxomicin is a macrocyclic antibiotic. Macrocyclic antibiotic used for pseudomembranous enterocolitis. Alright. Then we have drugs which are going to inhibit the DNA gyrase. They are called as fluoroquinolones. So these are again bactericidal drugs. So what they do? They prevent the negative supercoils and inhibit replication by targeting DNA gyrase. So remember, the replication takes place like this and the bacteria need to unwind, right? So there's a nick or a cut which is given by DNA gyrase. But if you block this DNA gyrase, then the cut won't be visible. Then the bacteria will undergo extensive supercoiling like this. And ultimately, the strands are going to break. Like a rope, you see, like if you cannot unwind a rope, then if you pull the two ends of the rope, they are going to get so tightly coiled. This is the same thing happens to the bacteria, and therefore it can lead to the death of the bacteria. Now, which fluoroquinolone has the maximum oral bioavailability? And the drug is levofloxacin. Drug which causes maximum QT prolongation, maximum seizures. So remember this max. Max rhymes with mox. So it is moxifloxacin. Which of the drug is safe of the fluoroquinolone is safe in renal failure? So this is PMT drugs. PMT drugs stand for P-floxacin, moxifloxacin, trovafloxacin. Now remember, this is banned. Why? Because it was hepatotoxic. Maximum CNS penetration which can enter into the brain, that is P-floxacin. P size, small size, it can enter into the brain. Uses. First use, respiratory diseases. For example, in the MDR tuberculosis, we use respiratory fluoroquinolones. So, which are these respiratory fluoroquinolones? Remember, OMGL. Oh my God, Lord. Right? Oh my God, oh my good Lord. Whatever you want to remember. So, oh my good Lord. So, we have O-floxacin, moxifloxacin, gatifloxacin, and levofloxacin. Then a good fluoroquinolone for UTI or traveler's diarrhea, we have norfloxacin. Now, ciprofloxacin is very important fluoroquinolone. It is used in a variety of conditions. Number one, it is used for chemoprophylaxis of the contacts of meningococcal meningitis of these contacts. Number two, it is used for anthrax. Number three, it is used in typhoid. And number four, it is the only drug, oral drug rather, for pseudomonas, right? Only oral drug for pseudomonas. Adverse effects. Increase in the QT interval. Another important thing, again remember, increase in the QT interval. So what is it? Maximum. Remember the word maximum, that is moxifloxacin. Moxifloxacin. Phototoxic. Maximum phototoxicity is seen with spare the sun. Sparfloxacin. Right? So you have to spare the sun. Do not go in the sun directly when you are under the influence of these drugs. So spare, sparfloxacin. Again, these are contraindicated in case of pregnancy and in case of children. So these are some newer fluoroquinolones that we have. Prolifloxacin, it is given for urinary tract infection. Pazufloxacin, it is very effective or good against the Pseudomonas. Balofloxacin, again given for UTI and RTI. Dilafloxacin, D is dual. Two things it does. It is working against the MRSA as well as Pseudomonas. Zabofloxacin against the RTI. So we have Pruli, Pazo, Balo, Dila and Zabofloxacin. So floxacin, whenever it is, you all understand it's a fluoroquinolone, right? So mostly it will be about the ones which are active against Pseudomonas. So it is Pazufloxacin and Dilafloxacin. So with this, we are finished it with the drugs which are going to inhibit the protein synthesis and the ones which are going to inhibit the DNA gyrase.